Good morning, everyone, and I'll ask you to take your seats as soon as you can. I hope you all had a very good evening last night. For those of you who are at the conference dinner or other arrangements, I'm absolutely delighted to chair this session this morning. For those of you who don't know me, I'm John Cameron. I'm the CEO of the CSP since January of this year, so first conference, and have had a fantastic time. It's great to have seen you all and partaken in some great debates and great discussions. This morning, we're going to be talking about palliative care, and by virtue of the title, it is everyone's business, and I know that those in the room will be passionate about that. We will have 4 speakers this morning. The first is Professor the Baroness Finlay of Llandaff, who, as well as being the president of the Chartered Society of Physiotherapy, is also a cross-bench peer in the House of Lords and a professor of palliative medicine. We will then have Emily Stowe, a clinical specialist at Farley Hospice. We'll then have Anita Hayes, who is a clinical quality lead at Hospice UK. And then finally, we will have Joanne Bailey, who is a research fellow at King's College London. We're also joined by Natasha Richardson, who is from the Association of Chartered Physiotherapists in Oncology and Palliative Care. Natasha will join us for the questions. We'll spend about 40 to 45 minutes on the presentation, and that gives us ample time for questions. So please do think of your questions as we go through, and we will come to you. Just for those online, welcome this morning, and thank you for joining us. You also will have the opportunity to ask questions, and if you do so, the moderator will flag those to the speakers as we go through. So without further ado, I'd like to welcome Professor the Baroness Finlay.
Thank you very much, and thank you for coming. First session of the day. It's always a bit of an effort, isn't it? But I was delighted to be asked to speak, and I'm going to talk about myths and policy in palliative care. That wonderful building is where I now spend a lot of time, and there's a lot going on there, and I'm going to touch on it as we go. You're all aware of this, aren't you? Cicely Saunders' model of pain, that it's not just physical, but the whole pain experience is made dramatically worse. And we are well aware that in palliative care, we neither hasten nor postpone death. And that's a myth. People think that somehow people are being kept alive. We're not keeping people alive inappropriately at all. We're accepting death, but we do realise that the whole family are affected by somebody's death. And we need to have palliative care applicable early. We need to know that we can see patients really early on, not more applicable in our patients, I think, than almost any other area of medicine. And as you will all remember, 5 principles behind it. You can presume that someone has capacity, but it's capacity for that decision that they have to take at that time. So you don't need much capacity for simple decisions, like deciding what you're going to wear or what you're going to have for breakfast or whether you want to go for a walk. But the minute it's a big decision, you need a great deal of mental capacity. And that is impaired by illness, by drugs, by fear, by depression, and so on. And individuals need support. That's where I think, in a way, healthcare often falls down. We don't provide enough support to people for them to make their own decisions. And it's very evident when people find it difficult to focus, inundated with information about what's going on. They can't sort it out and they can't take decisions, and they're subject to influence and are vulnerable. Of course, we all make unwise decisions. I thought wearing these shoes this morning was rather unwise because they're hurting. We all take unwise decisions. But The problem is you have to filter out whether it is a safe, unwise decision or whether actually it's because they've been subtly coerced and coercion goes on behind closed doors. Best interest decisions, of course, you all know you have to consult everybody. And we go for the least restrictive option. But when disaster strikes, and it does when people know that they've got a life-limiting illness, they get a diagnosis. Yesterday, I was with somebody who said he's got a hospital appointment coming up on Monday. He'll get the results of his scans. He feels like the judge before knowing whether he's going to be sentenced to death or not. That's the reality for patients. They come in and they're really scared. They feel as if that's a huge hurdle, which it is because it's when they get information. And they're faced with many difficult decisions. But without rehabilitation going on from day one, whether it's a catastrophic accident, whether it's that they've had a catastrophic diagnosis, they need that support right at the beginning. There was a study showing high numbers of suicides in people faced with terminal illness, but actually it's not at the end. It's at the time of diagnosis. It's when they're given that devastating information. That's when we've got to get in there with appropriate support, listen to their needs. What do people actually want? Well, they want continuity of care. They want to know that they're seeing somebody who they've seen before. And actually, it's very often you that provide continuity of care in an extremely fragmented health service now. They might see 10 different doctors. They might see 15 different nurses. They're much more likely to just see one physio as they go through. That continuity is essential. They also want to know there's someone who they can call on when it's difficult, someone who's there. That means we've got to rethink our services completely. 7 days a week, not 5 days a week. Disaster strikes at weekends, bank holidays, Christmases, and so on. People don't want to be wait. They don't want to wait. They don't want to be signposted infinitely this way, that way, the other way. They want someone who takes them through the system gently and is there when they need them and they want to be listened to. And I worry about our obsession with not having people answering phones now and answer phones. I get really frustrated even if I'm trying to change an appointment and you get through to an answer phone. And sometimes the answer phone tells you that they're away and it was 5 months ago. They've obviously not changed their answer phone message, let alone have they listened to those messages? Who knows? The days of the secretary in the department who picked up the phone and knew people, I think, are days gone, but are much missed. And it's been a real false economy. And of course, people want to know what's happening and it's their data. And I worry that we've been over-possessive about information and data. So what about listening to patients? Well, I love this Chinese symbol because we listen with our ears, but we listen with our eyes. We listen with our nose. You can smell the patient who's got a UTI, can't you? You know what's going on, but above all, you listen with undivided attention and you listen from the heart. And you all know if somebody you're talking to is listening from the heart or is they're distracted, their computer screen, writing notes. And you use your mind to think and integrate everything. So the really important question is, what matters to you? And when you know what matters to them, you can then begin to help them reach their goals. But remember, what matters to you on one day might be different to what matters to you the next time. So you can't just ask the question once. What about quality in palliative care and end-of-life care? Well, people have lots of markers. I think there's a really simple one. Is it good enough for your mum? If it's good enough for your mum, then it's good enough for other people. A service that's good enough is there when it's needed. A service that's only there when everybody else is around, 9 to 5, 9 to 4 on a Friday, Monday to Friday, not the rest of the time. It's not an essential service. An essential service is there when the essential need happens. I just want to touch very briefly, and I know that I'm running close on time. I'm sailing close to the wind. But there is a real misconception about stopping treatment and whether we're ending life when we do. We are not. As you can see from this, if you think about someone with MND on a ventilator, and they say they no longer want their nippy on, they are withdrawing consent to ongoing treatment. You look after them during this phase. You look after them really carefully, intensively as they die. They are dying of their disease that they would have died of months previously without that intervention. That is not euthanasia. That is not ending life. The drugs that you give are titrated in to make sure that they have symptom control during that period, that they don't become breathless and distressed. The guidelines are all worked out, and the evidence is that they work really well. Probably about 30 minutes from stopping ventilation to death in most people, sometimes a little bit longer, but gentle and peaceful at their time. What about euthanasia or assisted suicide? It's in the news. It was on the news this morning. I was listening again. You give a massive overdose of drugs intending to end life, and you do not know how much longer the person would have lived for. My biggest prognosis mistake was somebody who in 1991 was referred to me, and the GP said, I'm only referring him because I can't give him a lethal overdose. He is desperate for euthanasia. I went out to see him that night. I was there till about 11:30 at night in his home. He was extremely distressed, desperate for euthanasia, with a really nasty, fungating looking tumour on his back. I looked after him. He was not easy to look after, not at all. 11 years later, he phoned me because his wife had been diagnosed with a malignancy. She died, and since then, he has looked after their 3 children himself and brought them up. He phoned me a few weeks ago, said, I saw you on the telly. What are you doing? Said, getting into trouble again. So what are the pitfalls when we talk about this physician-assisted death? Well, first of all, diagnosis. You'll all have seen patients where the diagnosis is wrong. Post-mortem show about 20% of people actually have a misdiagnosis, have untreated conditions that could have been reversible. The figures are not good. Prognosis, we really can't predict prognosis. I have to cynically slightly laugh when I hear people say, I'm surprised I'm still alive. Yes, because we cannot tell. We cannot predict how long someone will live. He was my worst prognosis mistake, but I've had lots of patients. I've met patients in Marks and Spencer's and thought, oh, gosh, I wasn't expecting to see you up and about and well at this point. It's great to see people outlive their prognosis. Sadly, some people die unexpectedly fast. Sometimes we think, oh, they'll be fine. And then you're quite shocked because you suddenly discover usually that they've had a P or something massive and they've died. But the one that worries me the most is coercion. Coercion behind closed doors. We know from the figures from Hourglass that around 1 in 5, 1 in 6 people over the age of 65 have been affected by abuse. Most of that is financial, it's emotional abuse, and it's neglect. We don't know about it, and people don't tell us. They don't say, I'm a bit suspicious that my grandson's milking my bank account. They don't tell us about the subtle coercion of, oh, look at the electricity bill. They can overhear the conversation that says, no, Gemma dear, you can't go on the school trip this year. We can't afford it. Those are coercive pressures on someone who's ill to feel that they're being a burden, that perhaps they should end their life. I've even come across families where they've been trying to persuade someone to not pursue treatment in a private setting. This was not in the UK, but it was in one of the Channel Islands, because, of course, they were going to lose their family inheritance. Had a patient whose family didn't visit much after her birthday, and then we discovered that their worry about her not having pain control and wanting her to have more morphine was all linked to the fact that her fixed-term life insurance policy ran out on her birthday. They lost about £11,000. They wanted a new car, she told us. So I think those are just some of the pitfalls. There are others as well. But what about our care plans? Well, we have to go back and look at them and renegotiate them all the time. We have to think what's going on. And what about eligibility? And how safe are safeguards? Well, no law can be 100% safe. Even Lord Faulkner, who had a bill down until 2 days ago, he's just withdrawn his because of Kim Leadbeater's, said we can't have a system that's watertight. A law by nature is not perfect. So what's involved? It's all in the news, and I just want you to understand just a few facts about this. This isn't one tablet and a Hollywood death. This is one from Oregon, but it's about 100 tablets. They've now stopped using barbiturates. It's a mixture of all kinds of things, including a massive overdose of digoxin, which I think is a horrible way to die anyway. It's not quick and easy. More than half the patients took between 53 minutes and 147 hours to die. 9 people have reawakened again. And there's a complication rate of over 6%. That's Oregon's own official data, taken that from their annual reports. What about euthanasia? Well, you'll probably all remember the awful cases of women who reawakened during cesarean section. I know somebody who reawakened during knee surgery, but it was because he'd been paralyzed with a pancuronium type drug. He actually couldn't signal that he was awake, so he felt everything. He said it was the worst experience of his life. But what you do, this is Belgian data, they inject a short-acting anaesthetic agent and then a paralysing agent. I've left it in the French for you, just so that you're quite clear. This is the original data. Over 2/3 of them are completely paralysed. We don't know whether they reawaken or not. Nobody's done the study. What about the rates? Well, the rates escalate. The red line is Canada. We haven't got the data from last year. The rumours are that it's probably about 15,000 deaths last year from euthanasia. That would translate on a population basis to about 30,000 here. This is not small numbers. The Danish Ethical Council looked at it. They looked at Oregon and they looked at the Netherlands because the two models had gone on for a time, and they concluded that it is in conflict with palliative care, and it's a risk that it would become an expectation aimed at special groups in society, and that's particularly those with disability and so on. So what are we doing in palliative care? Are we going to accept this? Are we going to say if the law changes, this is the road that we'll go down, we'll be part of it? You've all got to think about it, because there's huge pressure now to introduce this in this country, and everybody will be involved. The conscience clause, as written in the legislation I've seen, would only apply to the doctor who's actually doing the assessment. So it won't apply to the rest of you, as far as I can see, because you'd still have to be looking after the patients and interacting with them even during their assessment period. And you'll have conversations with them, and you might discover what's going on behind it all. But I do think that we need to keep our core values and keep looking after our patients to improve their quality of life, and remember what we're really doing. Thank you for listening, and I hope that little rundown is helpful. And I'm going to unashamedly advertise our book, which came out this week on Monday. If anybody wants a discount card, stop me, because you can get 20% off. But on Monday, we launched a book called The Reality of Assisted Dying, Understanding the Issues. And we've got chapters written by people from right across the spectrum, Belgium, Australia, Canada, all around the world, as well as ethicists, and Nora O'Neill's written one on autonomy in there. It's a very short paperback. Thank you.
Laura, thank you so much, and as ever, hugely informative and contemporary, as you say, with the amount of media attention it's getting. Thank you so much, and I'm really pleased to introduce you to Emily Stowe, clinical specialist at Farley Hospice.
Good morning, everyone, and reflect what Laura said. Thank you very much for making the effort to get here for 9 o'clock in the morning after conference dinner night. So I really appreciate having you here. So you see the title of this is Policy Drivers in Palliative Care, and this is probably what you're doing at 9 o'clock in the morning after a conference talk. Policy is so important, it kind of underpins everything that we do. What I'm really going to try and do today is explain why the changes in policy that have been recently can make a real difference for us as physiotherapists working in palliative care. So the whole idea of the whole title of the talk is Palliative Care is Everyone's Business. And I'm aware that some of you in the room are palliative care specialists, others of you might well not be. But actually, for everybody, in almost every speciality, you are probably seeing palliative care patients all the time. So these figures, I'm sorry, you probably can't see the exact data. You'll get the slide. I assume we get the slides. Did the slides get shared? Yes. So you'll be able to look at that closer. But they looked at the amount of hospital days spent. And 50% of hospital days are for people in their last year of life. It's about 30% of patients in hospital in their last year of life, but because those patients tend to stay longer, it's 50% of hospital days. So if you're working on a general ward, if you're working in kind of an elderly care ward, you are seeing palliative care patients all the time, whether you think of yourself as a specialist or not. If you're working in a more of a community setting, we saw a huge spike in the numbers of deaths at home after the COVID pandemic. And we weren't sure if that was going to be just during the pandemic, but it seems to be kind of staying that way. So around about 30% of deaths now happen at home. So again, if you're in the community and you're seeing patients in that setting, you're seeing a lot of palliative care patients. So these are the new policies that we're going to talk about a little bit today. The ambitions for palliative and end-of-life care, it was a national framework. It was first launched in 2015 and then was refreshed in 2021. We're going to talk about the Health and Care Act and then the statutory guidance that was developed from the Health and Care Act and adult and child service specifications. So the ambitions for palliative and end-of-life care, the ambition is I can make that last stage of my life as good as possible because everyone works together confidently, honestly and consistently to help me and the people who are important to me, including my carers. And they spoke about having 6 ambitions to bring that vision about. ACPOP were involved in the refresh of the ambitions and we're really pleased to be part of a huge group of people with a kind of vested interest in palliative care. The exciting bit is under the ambitions, and again, I appreciate you can't see this, but this bit is there. So under one of the ambitions, rehabilitative palliative care is highlighted as a key part of the ambitions to achieve the way that we can achieve that ambition. They talk about it maximising the person's independence and social participation to the extent that they wish requires professionals to work with and support the person in helping them to achieve their personal goals. That's our bread and butter, right, as physios. That's what we're doing all the time. It's so obvious to us, but having that embedded within these ambitions for palliative care is so key for us. So the Health and Care Act in 2022, I have to credit the fact that Laura, who just spoke, is almost entirely responsible for this happening. So I feel marginally nervous that I'm talking about this in front of her, seeing as she's defended this too in Parliament and all sorts of things. Integrated care boards have always had a legal responsibility to commission healthcare services that meet their population needs. Before 2022, certain things were specified, so things like midwifery and dentistry, things like that. But as of 2022, palliative care is now specified in that Act. So that means that whereas in the past, an ICB could essentially decide what they wanted to commission in regards to palliative care, it's now in there. This is Laura in Parliament presenting that Act. I won't read this whole slide because I appreciate there's a lot of information there, but the key thing for us is about having a skilled workforce. So part of this is having the right people in the right place to deliver that specialist palliative care. Following that Health Act, the NHS England developed statutory guidance for the integrated care boards. And they stated, the key thing for us is they stated that the ICB should be using the ambitions framework to evaluate and commission services. So the law says they've got to commission services. The statutory guidance says they have to follow the ambitions. We go back to the ambitions and rehabilitative palliative care is in there. So that kind of gives us that thread to kind of justify our existence within a palliative care setting. A little bit more detail about that statutory guidance. So it spoke about people having the right knowledge, workforce with the right knowledge, the appropriate skill mix, and sufficient workforce as well. So again, the ICBs must look at ensuring they meet those criteria in commissioning their services. Adult and child palliative care service specifications were then developed in January 2023, and this document provides a service model for delivering specialist level palliative care from identification of need through to end of life. Rehabilitation's there. Woohoo! So we're in there. Again, this is that service specification that people should be working to. This particular section, it's a big document. This image is from the adult one, but actually the child palliative care service specification is very similar. But it talks about referral criteria. I don't know if any of you have worked in hospices or have tried to refer to hospices sometimes in the past. If it was a purely rehabilitation need, some hospices would reject that referral and would say that they didn't have enough complexity of symptoms. But actually it's now stated that rehabilitation is a good reason for referral to palliative care services. So we can, again, you know, when you get that referral through, you can say, yes, we can take this. You kind of can't reject those referrals in quite the same way as we used to. And look, we're there too. We're all over the place. It's exciting. This is around staffing requirements. So this is that the specialist palliative care MDT should have access to have input from the following professionals with specialist skills and expertise in palliative care, and physiotherapists are right at the top of that list. So again, it's just saying, you know, we should be part of that MDT. There are still hospices out there that don't have physiotherapists as part of them. There are still hospices that have one working 2 days a week, but that's kind of in amongst other stuff. You know, there is an awful lot of disparity. Whereas my hospice, we're in a very fortunate position. We have 4 of us working across locality and we're not an enormous hospice. So it's important to kind of highlight the fact that we should be there. I guess the subtlety in this is that it doesn't say the physiotherapist has to be working within the specialist palliative care team. It could be that they have access to a community team, but it does say that person has to be specialist. So actually, you know, it's that idea that if you're the person in the community team, you should have some kind of level of speciality working in this field. But policy is only as good as its implementation. It's all very well having all these policies in place, but at the end of the day, those commissioners have got an awful lot of things to think about. So unless we're raising our hands up and going, hey, did you know you're supposed to be doing this? It's not going to happen. It's our responsibility to facilitate this. Nobody else is going to do that for us. Strategies for influencing change could be an entire talk, let alone probably an entire conference. So I will direct you to the NHS Sustainable Improvement resources because they're really handy. But just a few ideas about how to kind of try and influence some of this change. The key thing for me is understanding your commissioners and understanding what their drivers are at the time. So are they really thinking about hospital admissions avoidance? Are they thinking about reducing inequalities in care? Are they thinking about personalised care? What are they looking at the moment? And kind of twisting your service to kind of fill that need. So are they looking at reducing inequalities? Well, actually, as physiotherapists in palliative care, we do an awful lot of the non-cancer workload. And actually, there's a real inequality in people accessing palliative care that have a non-cancer diagnosis. So we can stick our hands and go, hey, we can sort that problem for you. You know, that's our bag. And do your prep, understand your service, know what you're going to cost to deliver that service. What are you going to save? It's horrible, but that's how commissioners work, isn't it? What are you going to save by putting your service in place? So really trying to push that forwards. And that is me done. I think I've come within my 10 minutes. Really happy to take questions. I think we're doing them at the end. So thank you very much, everyone.
Emily, thank you so much. And yes, we'll take questions at the end. So just to remind both if you're in the room or indeed online, to think about the questions for when we finish the presentations. I'm delighted now to welcome Anita Hayes, who is Clinical Quality Lead at Hospice UK.
Thank you very much. Thank you. And good morning, everyone. It's really lovely to be here. I'm delighted to have been invited to join the panel today. And I am the Clinical Quality Lead at Hospice UK. For those of you that don't know Hospice UK, we're the national champion for a community of hospices, of over 200 hospices across the UK. And our mission is to promote and protect hospice care for all who need it for now and forever. And We also host the Dying Matters campaign. So the Dying Matters campaign, under which you have that strapline of let's talk about it. So I want to kind of spend some time just thinking about what that looks like from a Dying Matters perspective. And to kind of, again, think about that focus from, we only have one chance to get it right. And thinking about actually, you know, that, again, that quote from Cicely, you matter because you are you matter to the end of your life, and how people die remains in the memory of those who live on. So I also wanted to say that as a nurse, I'm hugely privileged to work with many physiotherapists over my clinical career, and absolutely that focus of rehabilitation from day one being really, really important. So I'm really, really pleased to be here. So I'm just going to say a few things around thinking about how rehabilitative palliative care is supporting and how, you know, we see people in terms of what matters most, and optimizing that care and support. So just a note there about that wider picture. And in 2021, across the globe, the UK was highlighted and ranked as #1. But we've got much, much more to do, haven't we, in terms of palliative care. And the second slide, the second reference on here, you can see is from the Lancet Commission, talking about the value of death. And really, I think this is really pivotal for us in terms of thinking about the principles that it outlines and the things that we need to be thinking about and considering in relation to what good looks like as we go forwards, and how we redefine and reframe that. So thinking about the wider social determinants, and thinking about those principles there, about death being psychosocial, psychological, emotional, and not just about that physiological event, which we all know here. And again, I think, you know, when we think about those social determinants, and Laura was talking about people living in poverty. And again, at Hospice UK, we just recently published a report about people living in financial hardship. Very hard reading in terms of thinking about what that really means to people accessing supportive and palliative care. And also when we think about death being recognised as having a value, and what that really means to us. So again, everybody's business. We can see here on this slide, and Emily's just highlighted this, increasing numbers in projection of people who will die. And again, this is taken from an ONS data projected through to 2043. And you can see that huge increase in numbers of people that we will be seeing die, and that we will need to be thinking about how are we going to be supporting their palliative and end-of-life care, and what does that look like in terms of valuing death and thinking about our community, and thinking about what those wider determinants and how we support that. So what I wanted to do really is to share some very practical resources, and doing that really through the lens of signposting you to references that are practical. So for those of you that this isn't an area that you are, that you are that familiar with or working in, and so you'll see all these references on here, but, you know, how do we know? And Laura talked about that prognostication. Well, we don't know, but we do have on here two indicators in terms of how we might identify who those people are who may be likely to die within the next year. So we've got the gold standards framework, which was pioneered by Professor Kerry Thomas. Some of you may be familiar with that, but really that proactive indicator guidance, providing some triggers to consider in terms of how we understand who may be in the last years, months, days of life. And again, the prognostic indicator guidance, looking at clinical indicators of advanced illness. And then on the second reference you've got on there is from NHS Lothian, and that's the supportive and palliative care indicator guidance. Again, with those indicators and considerations. Does anybody here use or familiar with the gold standards framework or the SPIC tool? I can see one nod at the back. Is that something? Yes, one or two. Okay. So we all see that. You'll see the gold standards framework within primary care, within hospitals, within care homes, very much focused around needs-based, around identifying who those people are and then assessing and planning care. So it's very much about that care being planned ahead and being proactive in thinking about what those needs are ahead of time, and making sure that we are beginning that process of having those conversations, but in terms of developing those care plans of what matters most. This was taken, and this was published before the ambitions. It was undertaken back in 2014 by National Voices and in collaboration with the then National Council of Palliative Care. But was very much, and you'll see that statement, Emily read that statement out, it still remains within the ambitions document, but very much about what it is that's important to people as they're approaching the end of life, in terms of that communication, that coordination of care, those people being important to a person, and that respect and dignity and care coordination. What's interesting to me, having worked in palliative care for many years, and also makes me very sad, is the findings that have just been published from the Time to Care report that's been published by Marie Curie and King's College, and it was presented at a clinical echo just last week at Hospice UK by Professor Bliss Murta. It's a post-bereavement survey, and it's the first post-bereavement survey that we've had really published since 2015, since the Voices survey. And it's a representative sample across England and Wales with a 39% response rate to that survey. I think 3,000 surveys were sent out across England and Wales. And the findings from that survey are really salutary in terms of where we are now. So it's something which I would signpost you to read, because I think, Emily, as you were talking there about the number of people who are receiving care in hospital in the last year of life, the data in terms of people people accessing ED services, people using ambulance services, people being, again, spending precious days in hospital at the end of life. So 1 in 8 people had a length of stay of over 30 days in the survey. And again, talking very much in the free text narrative about the experiences of carers not being able to access advice and support, not being able to access support through primary care, and not being able to access specialist palliative care. The other survey that was spoken about at the last week's clinical echo, which I think is really important, is the efficacy of specialist palliative care. And again, the analysis looking over 24 years of evidence base to show the efficacy of palliative care. And absolutely, we know specialist palliative care works, but it's the timeliness of access to that specialist palliative care. And as Professor Bliss Murta talks about, the dose of palliative care being too little, too late. So when I look at this and I think about what it is that's important to people, I think we have very far to go. And I think, as Laura was saying, as physiotherapists, you very often are the people who provide that care and continuity to patients. So communication, again, Dying Matters Awareness Week last year was focused about how we talk about dying, matters. And again, I just wanted to signpost you to some fantastic resources that were developed with Dr. Lucy Payne and other colleagues, bringing together a whole range of podcasts, but also book lists and many ways of thinking about how we have those conversations, but also thinking about that question about, you know, what is it about you that I really need to know so that I can provide the very best care for you. Again, you can see here that there's lots of information here around what matters conversations, and that progression from having those conversations when we're well, thinking about what's important, if we have advanced illness, who do we want to be caring for us, where would we like to be cared for, and you know, what is it, how will we make those decisions, what information would we like to receive, how would we like to receive that information. And I think with this, you know, it's that nothing about me without me, and I think that whole focus about involving people in those decisions. And again, here you've got signposted to those universal principles for advanced care planning, and I think we're thinking about care planning for the future. We know that will change over time, and we know that, you know, people will change their minds about what's important, what they would wish for. So that whole process of offering that conversation, but that being an ongoing conversation. So again, a range of resources to share. And again, I think, you know, we're talking earlier around the importance of education and training, and some of these resources being fantastic for, and I can see the red card there, but being fantastic if you are teaching, and you know, you have 10 minutes, there may be something here that actually will give you that resource to have that conversation. Okay, so I'm going to speed through. I know that Laura was talking about mental capacity, and every one of us has a responsibility, don't we, around assessing that mental capacity. And again, resources for professionals there. And maximising care and support. So I'm going to speed up a little bit here because I had the red card. But I think I just wanted to kind of highlight again, so the focus here around care and support, and the role, really, the huge role, crucial role that you play in providing that support in terms of that very proactive rehabilitation from day one in terms of care and support. I just wanted to say something about carers. I also had to include this quote at the top here from Dr. Julian Abel from Compassionate Communities UK, because I think that is so, I just feel that that's so poignant in terms of actually how we are changing and how we are valuing those difficult times and things that are difficult in that journey towards dying. And carers, I think, you know, we know that huge importance. We know that many of our out of hours calls, many of our unplanned hospital admissions, many of our crisis situations are because of carer fatigue. And so just wanted to highlight again that huge role you play in supporting carers, in teaching carers how to support people to stand up, to get out of bed, to support them with their home oxygen, all of the things that I know that, you know, you do in your roles as caring. And I think that the other thing I wanted to highlight is the carer needs assessment tool, again, that is really supports you in that assessment of carer needs, and that's really crucial, as well as our care of the patient. And care after death and bereavement support. And I think, you know, in the Time to Care report, this was something that, again, was very salutary reading for me, was the traumatic grief that people were experiencing after a death, particularly when they have had a huge challenge to access care and support, to access health and care services, and feeling exhausted, lonely, and not knowing where to turn. there are many resources for bereavement. And the other thing I wanted to highlight here also is the support and information that is there for professionals on the Hospice UK website, which was developed with NHS England to support professional nurse advocates and professional midwifery advocates, but would suggest it's equally as helpful for physiotherapists and any other members actually of the multidisciplinary team. And also for us to always think children. A colleague I work with asked me the other day if I could recommend any books that as parents we could read to our young children. I think I just wanted to just reflect that, because we must always think about children who may have lost a parent, a family member, a friend, and just thinking about the resources that Child Bereavement UK have in terms of very practical things that we can access and use. Thank you. Yeah.
Of time, if that's okay. I mean, a huge amount of resources there, and I'm sure a lot of things people can take away. Thank you so much, Anita, and sorry to interrupt there. Thank you. I'm really pleased to invite Dr. Joanne Bailey, who is a research fellow at King's College London.
Oops, go back. Yeah, so physio by background, worked clinically in a hospice in Liverpool for just under 20 years before moving into research and to do my PhD when I just turned 50. So those of you who are younger than me in the audience, it's never too late to move into research. I'm going to give a bit of a rationale for palliative rehabilitation. We've heard about the kind of strategic and what I would call the macro level of delivering rehabilitation in palliative care. I'm going to get a little bit more down to the nitty-gritty, what it looks like when you're actually working with a person. I'm going to introduce another policy, which Emily didn't mention, which is a policy brief we published last year on integrating palliative rehabilitation into palliative care, and just give you a little bit of an insight into a research study that I'm currently running at King's College London. There is a bit of a focus on cancer. I'm not ashamed of that. Mostly it's because that's where my research is, but also I figure for the last 20 years in the CSP as a physiotherapist, I think cancer is under-focused on. The rest of the healthcare system and palliative care focuses more on cancer, but physiotherapists, I think our research base is stronger in chronic obstructive pulmonary disease, in chronic long-term conditions, in geriatric care, and physiotherapy in cancer care, I think there's an under-emphasis on it, despite the number of people who are going to live with and die with cancer. When people think of cancer, I bet they don't often think of disability. Cancer is an illness, isn't it? And yet actually cancer is strongly associated with disability. And if you get a diagnosis of cancer, you are entitled to disability benefits. And not only is cancer associated with disability, cancer is very much a condition of older populations. So people who are living with cancer might also be contending with the effects of aging and chronic long-term conditions. And we know that more than a third of adults with cancer experience difficulties with personal activities, and more than a half with personal activities, and more than a third with getting around and shopping. And we know that disability reduces quality of life, and it's associated with admissions to emergency departments and to hospital. And once people are in hospital, disability prolongs the hospital stay and makes it harder for people to get home. And loss of function is rated as one of the highest unmet needs for people who want to live as normally as possible. And interestingly, the SPICT tool that Anita just shared with you before, if you look at the SPICT tool, which is for referral to palliative care services, a lot of those indicators relate to function. And yet when people get to the services, when people get to the palliative care services, are there actually services within palliative care orientated towards supporting people to optimise their function? And I would say within palliative care at the moment, often the answer is no. We're very underfunded within palliative care. But we do know that people want to live as normally as possible. There's reams of qualitative research asking people about their experiences of living with life-limiting conditions. And these are some of the things that people say about what it's like to live with a life-limiting condition. And I think I'd hope you'd agree with me that as physiotherapists, we can address a lot of these things, can't we? We have strategies, interventions to address a lot of these needs and goals that people living with life-limiting conditions have. And yet, rehabilitation is underfunded and under-resourced in palliative care. And I think that might be because of the models of rehabilitation we have in our mind. When you tell somebody that you're a physio, I bet you'd be a millionaire for the number of times people have told you about the pain in their back, or if it's a bloke, their groin. And if we think about where rehabilitation started, if we look back in history, rehabilitation started as a trauma-related profession. It was aimed at getting soldiers back to the front line or workers back to the factory. There's a really good book by Dave Nichols on that. I'd recommend it. And then over the decades, rehabilitation developed in stroke and in cardio and pulmonary rehabilitation. When I newly qualified as a physio back in 1987, the first pulmonary rehabilitation trials were running across the UK, and the hospital I was a basic grade in was involved in one of those trials, and people were very nihilistic about it. People didn't expect people with COPD to be able to participate in exercise interventions over 8 weeks, and now it's gold standard treatment. If it was a drug, it would be a blockbuster drug. And cancer rehabilitation is an even newer phenomenon. And I worry with cancer rehabilitation that it's becoming conflated with exercise therapy. Rehabilitation includes exercise, but it is far more than exercise. Exercise benefits people who are able to and willing to participate. But there are many people in our population who are aging with comorbidities and in different social circumstances. Exercise is not necessarily the best intervention for them. So, does your rehabilitation accept referrals for people in the last year of life? If you're in a rehabilitation service and you are a recovery-orientated rehabilitation service, but you can see that somebody still has functional needs, where can you refer them on to? Who can take them on when your time-limited service is completed? The World Health Organization it's a very useful organisation, published universal health coverage. And universal coverage now includes palliative care and rehabilitation as essential items in quality healthcare. And this gives us an opportunity for synergies. We can bring both of them together because although we're organised around complementary goals, bringing both of these goals together provides even better care for patients. Palliative care is traditionally orientated around minimising suffering. The slide that Elora showed before from Dame Cicely Saunders about total pain. And as physiotherapists and rehabilitation specialists, we're about optimising functioning. But a lot of suffering is related to loss of functioning. Think about you've slept upstairs in your bed with your loved one for the last 30 years, and now you're struggling to get upstairs. They've told you you've got to have a bed downstairs in the sitting room, which is the room that comes in people walk in off the street into this sitting room, and you've got to have a bed in there. And you can't sleep next to your husband. And because there isn't enough room for a double bed downstairs, there's only enough room for a single bed. Think how much suffering is associated with that. And yet a simple, small dose of palliative rehabilitation might help you get back up the stairs so that you can live in your own bed. You can sleep in your own bed. Likewise, we need palliative care specialists, our medical and nursing colleagues and our psychological and counselling colleagues to help to reduce existential suffering so that people are able to participate in rehabilitation, so we can work with them to optimise their strength, strategies for getting around their house, strategies for managing activities of daily living. Bring palliative care and rehabilitation together, we can optimise functioning and reduce suffering. And the goal of palliative rehabilitation is very like geriatric rehabilitation. It's to compress functional decline. We want to keep the curve, the dotted line that you might be able to see is the absolute ideal, which I'm sure all of us would love, to be able to do absolutely everything we want to do right until a few hours before we die. But we can hopefully move towards the orange line and get away from the blue line with really good palliative rehabilitation. We can help to improve people's ability to participate in their social and daily activities. We can anticipate and minimise deconditioning. Palliative care is a preventative discipline. We know that people are going to decline, but how can we mitigate that decline? How can we minimise the speed with which that decline happens? And that's often addressing symptoms. Symptom control is a medical and nursing activity, but there's an awful lot that we can do to minimise symptom control. Helping somebody to know how to stand up from a chair really simply can reduce pain on standing. Instant pain is one of the most difficult pains to control with medication, and often it's physiotherapy and occupational therapy strategies which can really help to reduce instant pain. Helping people to manage their activities and participate reduces social isolation and can have quite a profound impact on psychological indicators as well. And it helps people to maintain their sense of self, their sense of identity and self-worth, never mind potentially reducing health costs and maybe even improving survival. The key thing, the one thing I want you to take away with today, is that palliative rehabilitation is about supporting people during recovery and decline. Rehabilitation is not always about improving function, and yet most of our rehabilitation models are around improving function. And if somebody doesn't have the potential for rehabilitation, they haven't got rehabilitation potential. How often do we hear that? Have they got potential to benefit is what we should be saying. So we support functional improvement, but we also support functional decline. And we want to challenge the nihilistic attitude that views functional decline as inevitable and look for opportunities to optimise function. And I'd thoroughly recommend these two books to you. I think they should be compulsory reading on the undergraduate curriculum for all healthcare professionals. Javi Carrell particularly talks about how people have a negative deficit approach. They want to know how her body is, how her body functions are. They don't ask her about how her life has changed. And she says we should creatively help people to reconfigure the ability to be. Our lives are always changing what we can be, from being a child to an adult, to being an older person, to dying. How can rehabilitation help the person in this phase of their life to be the person they want to be? The policy brief I'm going to just quickly flip over, but it's free to download, and it provides evidence, the up-to-date evidence of where we are with palliative rehabilitation, but also evidence related to barriers and solutions that you can use if you're developing business plans. I've got my red card now. And this is the trial, just to finish with. It's being conducted in 6 countries across Europe. It's just one model of rehabilitation, but I'd encourage you to look it up. We're aiming to optimise symptom control, physical activity and fitness, and social participation. It's delivered by an occupational therapist or a physiotherapist over 3 sessions over 49 days. And our primary outcome is health-related quality of life. It's tested in a feasibility trial and theoretically informed, involving patients and carers. And we've actually up to 60 participants. We've recruited 60 participants now. And so that's my take-home message, which I'll leave up. And you can download the brief from that QR code, or you can go to the website from the trial for that QR code. And do keep in touch, especially if you're considering researching another model of rehabilitation in palliative care. And I can see another researcher in the room I'm looking forward to chatting with after, who's doing just that. Thank you.
Thank you so much, Joe. And could I ask the 4 speakers and also our ACPC OPC rep? I'll get out of your way. Thank you very much. So just a reminder to those online that if you have any questions, please pop them into the chat and our moderator will pick them up. We've had amazing interaction with those online all through conference, so thank you for that. So any questions for the panel? Thank you.
Hi, good morning. Hello, I'm Mary. I work in a hospice in Huddersfield in West Yorkshire, in a little bit of a strange role, but I am a physiotherapist by trade. But one of our biggest challenges is that people think that we are a building where you come to die if you have end-of-life cancer. And so what we've done is try things like we've taken away all referral processes. People can pick up the phone. Like, what we would hope is that after that appointment where they get the diagnosis, they would phone us. We've been trying to go out to communities, do more of that place-based work, and, you know, just really try and really myth bust. But our job, we feel, will never be done. And I will never make the presumption that people don't think we're just about end-of-life care, down to my GP colleagues. Our hope is that when someone goes to get their hair done and they mention that a loved one's been diagnosed with dementia, that hairdresser will say, have you thought about the Kirkwood? Because that's where I work. What are your thoughts on, I suppose, the narrative change that needs to happen so people can access palliative rehabilitation? You know, people can get there sooner and keep well for longer. That was my thought.
Thank you so much. Yes, Alora? I think if you move down to the, oh, great.
I think that's a really good question. I have an opinion about this, and I think it's to get rid of silos. I think we end up with path dependencies. Hospice started it for a very good reason back in the 60s, but that model of care that we have now, which is just for end-of-life care patients, is it really suitable going forwards when we see how many people are going to die in the future? I think we need to move hospices out of the silo of end-of-life care and create a much better link between the management of long-term conditions and the end of life. A lot of the long-term condition management programs, once you've completed your pulmonary rehab, once you've completed your cardiac rehab, once you've completed your falls program, what happens next? You know, people get to an end and then there's a complete gap until, like you said, they are finally persuaded to get to the hospice. If these beautiful hospice buildings could reorientate and were funded properly by the NHS to be rehabilitative palliative care centres in the community, then once people are moving towards the end of chronic long-term condition management, they can just segue into these beautiful long-term palliative care settings in the community. I think that would make a massive difference. Too much of palliative care at the moment, probably because of the funding crisis, is you only get referred to a hospice if you've got high intensity needs that require specialist medical and nursing. The lower intensity needs, as they call them, and I hate that term, but for specialist psychological and rehabilitative therapies are not at the moment prioritised in hospices. But I think that's where we need to bring the gap. Bridge chronic long-term condition management with end-of-life care in hospices.
I know it well. The hospice I set up years ago was known as a death house. And how we got over that was by outreach, by going to see patients wherever they were, bringing them into daycare, bringing them in for a short time. And I very often said to people, half of our beds are for people like you who've got a problem. You come in, we sort it, and you go out. It's a revolving door, and then we get you home. Yes, the other half of the beds are for people who can't go home, and they will stay with us till they die. Of course, everyone thought they were coming into the first half, and sometimes they transfer to the second half, but so be it. Llandudno Hospice set up a cafe in its front area. We've done a similar thing down in Penarth, trying to make it more open for the community, and then having people from local schools come in, sixth formers come in and do little bits of voluntary work so that you really become a hub in the community. The other thing we did is that we got all of our specialist staff onto NHS contracts, and that meant that they could move around much more easily. And so the doctors are all on NHS contracts, and they work in the hospitals and in the community and in the hospice. So we don't have that little sort of silo of people. And it was people coming and going all the time that broke it down. And then we made quite a lot of fuss about people going home in the community so that we were visible.
Fantastic. Thank you so much, Laura. Any more questions from the floor? I had a couple of points. I mean, there was certain things within the presentations that I thought were really quite profound. I loved your analogy that if pulmonary rehab was a drug, it would be known as a super drug. I thought that was a really interesting analogy and one that could be used across huge ranges of the work that we do. Laura, I think it's a question for you, but I'm sure the others will have something to say. How do we get out of this conundrum where the NHS are not funding this type of care to the level they are? It's been something all the way through my career. Both my parents had an amazing experience in Dublin with the hospice care and palliative care before they died, very peacefully and very happily. But what is it? What is it about the NHS that they just will not fund this care?
That really interesting question. I mean, Cicely set up hospices originally because she knew that to turn around the tanker of the NHS was impossible, and she could change things more quickly. And of course, that means hospices have developed in areas of more, well, I won't say plenty, but better wealthy areas. And then we've got black holes. What we did in Wales in 2008 was Edwina Hart, the minister then, asked me to implement a strategy. The strategy had been written that we had to have fair access to palliative care wherever we were. I had a budget of £2 per head of population. A lot of money, £2. I mean, you know, inflation is probably worth about £1.50 now, per head of population to change this. And so with my colleague, Andy Fowle, who sadly died in a cycling accident some time ago, we sat down and for months, we worked out a funding formula and we put it across Wales so that across the whole of Wales, we had a minimum level of specialist palliative care that had to be available, that was the multi-professional team. I had previously been involved in the Kalman Hein report over cancer services, and I was the one that got physiotherapy into that report back in the 1990s. So I just have to do a bit of self-publicity there, because nobody else mentioned it. So I've been a bit of a fan of physio, as you realise, for a long time. So we set a minimum level, a floor. Now, the hospices didn't like it, but none of them lost any money. They just didn't get a big share out of my £2 per head of population. And we also went to 7-day working. And that funding formula was resisted by England. And I think they're finally coming round to the fact they've got to have a funding formula, because without a funding formula, you will not get the implementation by the ICBs against those standards that were so beautifully outlined. Thank you, Emily. Because they're just strapped for cash. They're all in deficit. Trusts are in deficit. Everywhere's in deficit. And unless you actually lay out what your minimum level is, that isn't ideal, but it's better than nothing. You know, if you've got nothing, anything is often better than nothing. And I think we need to really change the way that it's handled.
And I want to add something.
Yes, please.
I guess just a slight other viewpoint on it as well. As much as we all want more NHS funding, there's also this slight undercurrent of, you know, I work for a hospice. It's an independent charity. Actually, we get to do stuff because we're a bit charitably funded as well. You know, if I want to spend 2 hours with a patient because that's what that patient needs, I can do it. I spent an entire day getting a lady to go and view her daughter's home that she'd never seen before. And there is absolutely no way, I appreciate that, I would be able to do that in the NHS. So there's this slight tension between, yes, we want more cash, we all want more cash, but I don't think we'd want to be 100% NHS funded, because it would take away some of that freedom.
Nobody's talking about 100%. It's about the floor. It's about filling the black holes. And yes, the fundraising is across all disciplines, Heart and Lung Foundation, everywhere. You do the extras because you fundraise and you can do them. That rapid innovation is really important, but we've got to have a floor.
Yeah. I think as physios, we can contribute to this by being much better at collecting data related to function. In your organisation, what data do you collect relating to the difference that you make to your patients' lives, which isn't always improving function? You know, it can be about providing really good compensatory mechanisms and supportive mechanisms in a timely manner that enable the person to benefit and stay at home for longer. So record outcomes relating to function. I haven't got time to explain those now, but if you want to ask us questions about that, come up and see us afterwards and we can give you some places to go.
We do genuinely have time.
And collect data from the family and relatives as well. Quick advert from 16, developed at Cardiff University, takes 2 minutes to complete, assesses the family's impact of what you're doing. And if you'll find that the relatives' lives are transformed by your impact with their relative. And that is huge for the country's economy, because they can perhaps get back to work during the day.
That's called, we call that informal care.
I think it's worthwhile when you said the FROM, the family related outcome measures, because from that very humble coffee that we had when we met in London that time, and we all talk about patient related outcome measures, but you left me really thinking after that conversation, Laura, about the family related, particularly for this, and no doubt for pediatrics and also for long-term conditions. Apologies, Anita, again. Yeah, you're welcome. No, sorry, not Anita, wrong. But yes.
Very definitely going to look for that measure. That sounds great. But your hospice, your palliative care, your service may already be collecting outcome measures, but just review them and see whether they're good. And are you collecting them at the right time? And not only collect them, but shout about them. Tell people about them. You know, it's easy to collect data. It takes a little bit more effort to do something with it and to make a story with the data. You don't just want tables, you want a narrative to go along with that. What difference did it make? Because that's what the funders of your service will want. They'll want to see the figures, but they'll also want the story about what these figures mean. And if we don't do that, if we don't tell our story with our data and our narratives, nobody else is going to do it for us.
wondered, Anita, if I could
Can
bring
I,
you.
can I just,
Sorry, yes, you can.
can I
of
just
course.
add one thing? Data gets into the head, the story
Yeah.
gets into the heart. Do both.
I just wondered, Anita, you know, some good questions there about maybe the future and also about some of the key challenges that we're facing. And just from Hospice UK, some of your kind of insight into, you know, what's needed now and what's the direction of travel, I guess.
Yeah, thank you. And I think just thinking about again that funding model, and the challenge not only of money, but is also of resource and workforce. So I think that. Sorry, did you want? So, you know, I think that one of our greatest challenges is our workforce and thinking about having, you know, enough resource. And so when I think about that Lancet Commission report, and I think about actually how we're going to, what that direction is in terms of us really valuing death, being able to think about those social determinants and that wider societal impact, the need for us to be much more integrated and working together on that, I think is really, really important. And I think, you know, as Joe was saying, breaking down those silos, you know, we know that specialist palliative care is effective, but we know it's too little, too late. Yeah. So I think, you know, that direction of supporting and working with our workforce for the future has to go hand in hand with that funding, having that funding model and knowing what that minimum is, but also thinking about, you know, where that spectrum, if you like, of funding is supporting our service provision. And I think that, you know, we know a lot about cost, and we know, you know, about outcomes, but actually I think what we're not also particularly good at across our hospice sector is describing our service models, because we've got so much variation. And so there's something about, going back to the point Emily made earlier on, about us being really able to articulate our service model, you know, who it's for, what it's for, how we're doing it. And I think, you know, Joe talking about a new model, an integrated model that is that continuum, and dispelling, you know, those myths. So I think there's lots for us to be thinking about. And I think, you know, from a Hospice UK perspective, the strategy is that focus on equitable access, and it's thinking about that quality in the evidence base, but also thinking about sustainability, both in terms of funding, but in terms of workforce for the future.
Right. Thank you so much. Question from the floor here.
Thank you all for a very engaging discussion. My name is Rebecca Taburin and I chair the Rehabilitation Task Force for Palliative Care for the European Association of Palliative Care. And I also provide coaching and clinical supervision for physiotherapists working in palliative care. And some of the reason that I've gone into that area is because, having worked in palliative care as a physio for many, many years, I found it really quite a lone role that, as you were saying, they are often very small numbers of physiotherapists working in this area. And when you're super busy with a clinical caseload and trying to meet these growing demands, which we've seen, and yet, on the other hand, as you beautifully presented, Emily, we need to be advocating for more physiotherapists in this area, and that it's everybody's business to respond to that. The challenge for me is, like, if we've got really good evidence that you're leading on, Joe, if we know that there's policy that says we must have access to specialist physios in palliative care, how do we balance this challenge of getting more physios in palliative care, really making it everybody's business? And so that's my question.
Right. And if we could bring Natasha in here, just, oh yeah, you should be fine. Yeah.
So I think that's exactly why we came here today, if I'm really honest, because although obviously these guys are absolute experts in their field, even more so than myself, and I think, you know, I definitely advocate that we need that specialist role. I think from my perspective, and from the network's perspective, what we're really looking to do now is think about, we hope we do get more money, we do want more roles, but the reality right now is that everybody is seeing it. So how can we get all of you, some of you may be specialists, some of you may be generalists, community workers, working in an acute hospital, and that's kind of my background. And I just think, how can I, with the knowledge I have, help those people who are working every day with these patients. As we said, 30% of patients we're coming across will be in the last year of their life. Most patients, if they're not elective, will be in a palliative or long-term condition management phase when they're in hospital and in the community. So how can we get some of these skills? Okay, they might not be super high-level specialists, but how can we ingrain that into general practice so you feel enabled to have some of these more trickier conversations and feel like you're giving your patients what they need in the context of this? So please reach out, even if you don't want to become a member, but if you want more info, reach out to the likes of us, find out more, because I think that's really where we're looking to go next, is how can we make everybody a bit more skilled and a bit more confident? Because you've got the skills, they're ingrained in us as physios, we're very, very good at it. It's not actually that special. It's just about how you think about it and how you use the medical background of the patient to help you make your decisions and support needs.
Right, thank you, Natasha. And Joe, I know you're going to come in, but let's take the last question from the floor here. Yeah, so let's take
Hi, I'm the physiotherapist at Jersey Hospice Care, and we have a draft in law on the 21st of May this year to bring assisted dying into Jersey. So from my point of view, I'm quite nervous, and I just wondered if the panel had any thoughts on this. One of the things I am reassured of is that I can only read what's in the States. We're not allowed an opinion, but it says that health professionals will be given training, and there'll be the development of accessible public information on assisted dying, and it will take 18 months, and they plan this to be in force in law by the end of 25.
Laura.
And I'm a lone worker as a physiotherapist, although HR are looking to get a second one.
I know Jersey Hospice well. I've got family in Jersey as well. We need to have a coffee. You have a huge problem facing you, and we'll talk about it later. But I think the lesson for all of the other physios here is that you need to think about it now. I don't have enough little cards to give you for a copy of the book that we've got people from across the spectrum, New Zealand, Australia, everywhere. A New Zealand doctor said to me on the phone recently, we were sold this as choice, but actually it's about rationing. I think it is something you have to think about very, very carefully. And I'm very worried if you're not being allowed to speak out, because freedom of speech is a core value in our country. And it is something that we really must not lose. And if there's anyone with a management system that's telling them to not speak out, no, we have freedom of speech.
So just from the fact that I have a real problem with assisted dying for me personally, I can say that in this room, not to be taken outside of the room. So, yeah, thank you.
Okay, thank you so much. We're at the end of the session, but what a fantastic conversation. And I think that the title of the session was Palliative Care is Everyone's Business. But certainly what I think we'll be taking away is the importance of the rehabilitative element of that palliative care. And I think that's been really profoundly spoken about this morning, and I'm really grateful for that. But as Laura says, there are many challenges coming on the horizon now with the conversations about assisted dying. We have somebody who is exceptionally knowledgeable, exceptionally clear, and I would urge you all to look at the evidence that's been offered to you today. So thank you very much to the panel, thank you very much to the room, and thank you very much to online. It's now a break, so if you'd like to take some time for coffee, etc., and then the following sessions that you choose.